So I'll be discussing about the basic principles of fractional flow reserve measurement. FFR is defined as the maximum achievable blood flow in the stenotic coronary artery divided by the maximum blood flow in the same artery without stenosis. There are two words that are important here. One is the word maximum and the second is the word flow. In routine practice, we measure FFR as the ratio of the pressure distal to the stenosis divided by the pressure proximal to the stenosis. But actually, FFR is a measure of flow and not of pressures. Now, how flow can be equated to pressures, we'll deal with it in a moment. The second and the most important point here is the word maximum. FFR, by definition, can be measured only at maximum hyperemia. There is nothing called the baseline FFR. If you are to tell that I have measured an FFR, you need to induce maximum blood flow, maximum vasodilatation, maximum hyperemia, and then only you can tell that you have measured an FFR. You may get a PD by PA value when you put in the FFR wire. You may qualify it as basal PD by PA, but not FFR. And there are a few studies to tell that when the PD by PA is less than 0.9, the lesion may be significant. How flow can be equated to pressures? The derivation of FFR equation is from the analogy of Ohm's law. With regards to electricity, electric current is equal to voltage upon resistance. When it comes to fluids like blood, flow which is equal to electric current is equal to pressure or otherwise voltage upon resistance. So when resistances are minimal at maximal vasodilatation and hyperemia, flow can be equated to pressures. And FFR assumes that there is a linear relationship between flow and pressure. So that's how flow is equated to pressure with regards to FFR. Now, as I told you, the most important thing is to achieve maximum vasodilatation. We should do so in both the epicardial arteries as well as in the microvasculature. And with regards to epicardial arteries, we use nitrates to relieve the vasospasm. The standard dose of nitroglycerin for measurement of FFR is 200 microgram and not the usual 100 microgram. And studies have shown that if you are inadequately using nitrates, it gives rise to poor FFR values and thereby poor outcomes. With regards to dilatation of the microvasculature, the most commonly used agent is adenosine. We may also use nitroprusside. Nicorandil we have used in a couple of cases, in a few cases at least. Papaverine not routinely used in our country. Ideally, it should be given by a continuous IV infusion, but the recent studies have all shown that IV adenosine and intracoronary adenosine are equally good enough. But if you are doing it as part of a research protocol or maybe assessing an osteal lesion, osteal LMC or an osteal RCA lesion, or if there is a difficulty in orienting the guide so that you are not sure whether your adenosine that you are giving is really going into the coronaries, it may be reliable to use IV adenosine. The dose, there are no ifs and buts about it. IV adenosine is best given at 140 mics per kilogram per hour, nothing more or nothing less than that. Intracoronary, for RCA, 100, and for left coronary artery, 200. And studies have shown that there is no added advantage of increasing the dose further. Ideally, it should be administered by a central venous vein, but peripheral administration is good enough. But it may be prudent to wait 20 to 30 seconds more if you are infusing by the peripheral vein, so that the circulation times are also taken care of. It's not only important to get excited about a FFR value, but also important to look at the pressure tracings. FFR is basically a cath of the coronary arteries, and we should look at the pressure tracings like in any other cath study. Normally, the PD and PA tracing should overlap and should look identical. With the onset of hyperemia, there comes a gradient in diastole first, and with the loss of dicrotic notch. As the stenosis severity increases, the gradient in diastole increases, there is a loss of dicrotic notch, and the small gradient appears in systole as seen in this moderate stenosis. When the stenosis is very severe, you have a large gradient in systole, large gradient in diastole, and there is loss of dicrotic notch. So you must have this mental picture when you are assessing a particular FFR value. At the end of the procedure, it is imperative that you pull back the pressure wire and keep the transducer at the tip of the guide catheter and ensure that it is all same as the place where you started. If you get a tracing like this, where the PD and PA values look identical with the presence of a dichrotic notch in the PD or the distal pressures, that indicates the phenomenon of drift, which is an inherent property of the piezoelectric crystal that is used to measure the pressure in the pressure wire. You have to go through the painful process of redoing the procedure again. It's also important to understand that FFR value depends on the viability and mass of the perfusion territory. I'll try to explain this concept with this cartoon. Imagine an artery with a 90% stenosis and is supplying an infarct territory. Similarly, imagine the same artery which now has a 50 to 60% stenosis and is supplying a normal myocardium, but is collateralizing an additional area. In the first instance, part of the normal myocardium is replaced by a scar, or in other words, the normal myocardium that is subtended by this 90% stenosis is lesser. In the second instance, there is additional area of myocardial mass that is attached to the normal myocardium, or the 50 to 60% lesion is now subtending a larger myocardium. So if you were to measure the FFR in the 90% lesion, it may come as insignificant or negative because the amount of myocardium that it is supplying is considerably lesser, or in other words, this lesion, although angiographically 90%, is not ischemic for the amount of myocardium that it supplies. On the contrary, if you were to measure the FFR in the 50 to 60% lesion with a larger myocardial mass, you may get a lower FFR value because it is now giving rise to it is supplying a larger territory of myocardium. I'll show this with regards to an example. This is the RCA of a lady with a 80% stenosis proximally who had an old inferior wall MI. We measured the FFR with an infusion of IV adenosine and the FFR value was 0.93. Nobody would have thought about it, but some part of the myocardium is lost as a result of inferior wall MI, and although the angiographic rate is 80%, FFR is still negative and she's on medical treatment. On the other side, you have an lady which has a seemingly 50% lesion and is now collateralizing the RCA territory. We would expect it to be negative, the FFR to be negative, but in this case, the FFR was 0.65. That's because there is a larger amount of myocardium that is supplied. So for a given stenosis, FFR correlates inversely with the mass of viable myocardium supplied. FFR is presently the gold standard for measurement of ischemia, for identification of ischemia, and a value of less than 0.75 identifies ischemia with a specificity of 100%. This has been shown in multiple trials after this seminal paper that was published in 1996, where they did FFR in all the patients, and 25 patients also underwent exercise stress test, thallium scintigraphy, and dobutamine stress echo. And if you are having an FFR value of less than 0.75, one of these tests will definitely be positive. The clinical threshold of FFR is 0.80, although the ischemic threshold is 0.75. And when you have an FFR of more than 0.75, ischemia is very unlikely and a sensitivity of 88%. So how do you interpret an FFR value that you have got? You must understand and accept that ischemia exists as a continuous variable and not as a dichotomous variable in nature. As the FFR value dips from 1 to 0.9 to 0.8, the MACE rate increases, with the steepest rise occurring somewhere between 0.8 to 0.6. It is in these patients who have the lowest FFR, who are at the highest risk of subsequent MACE, our interventions are really going to make a difference. The curve between the medically treated group and the revascularized group progressively decreases as the FFR value increases, and at a point which we believe and practice as the gray zone, the curves cross over and your interventions are no longer beneficial. And this gray zone is presently 0.75 to 0.8. So how do you approach an FFR value? It should be just like approaching a signal light. When the FFR is less than 0.75, it indicates ischemia, and go ahead with the PCI. When it's green. When the FFR is more than 0.8, yeah, I finished the last slide. When the FFR is more than 0.8, we usually don't do angioplasty. When the FFR is 0.75, it's in the yellow light. So on a yellow light, you may drive through, depending on whether you are driving on a dinner date or whether you are rushing for a primary angioplasty. Similarly, if you are having a value of 0.75 in a patient who has a definite stress imaging, a left main or proximal area where larger area of myocardium is at risk, a focal gradient or patient with refractory angina, please go ahead and do a revascularization. If it is a distal lesion with insufficient viability or other bleeding issues, minimal symptoms, maybe medical follow-up is good enough. Thank you for your time and patient listening.
Excellent talk, Dr. Murli. If there's any comment from the audience, we'll take this. Dr. Shastri.
Thank you very much. Good talk. I have a couple of points. Can you do FFR with a diagnostic angiogram catheter? And taking beverages like tea, coffee, couple of hours before, does it change the validity? And how reliable is it to assess the viability? Is there any gold standard compared to MRI or PET scan?
Okay, I'll take it one by one, sir. Studies of FFR have been done basically with a 6 French guide catheter on the 6 and 7 French. Of course, the other side of your question is you cannot use the largest guide because it might actually plug the flow. With regards to a diagnostic catheter, yes, we can do it, but what the innovators tell is that if you are to dissect, then you are dissect with the wire, then you are left with you have to change the entire system to put a stent. If you have to guide, it's easier. That's one. Second is there is some pressure difference on the PA, proximal pressures, that are measured between the PA of the guide catheter as well as the diagnostic catheter. So it is better to use a guide catheter to measure FFR rather than diagnostic catheter. Because obviously the lumen of the guide catheter is larger. Second is ideally coffee should be avoided at least 24 to 48 hours prior to the FFR measurement, although we don't practice it, but there are studies to tell that it will interfere with adenosine metabolism and results, although the studies are smaller.
Rajesh, how distally you want to place the FFR wire?
We need to go as distally as possible because to avoid the phenomenon of pressure recovery. Because if you keep it just distal to the stenosis, the problem is that the pressure would not have recovered. I have slides on that, but in the interest of time, I'm not.
Rajesh, excellent talk. So far you have been discussing about whether use of FFR to decide on whether to revascularize or not. Whether your revascularization was a perfect one or not, how to optimize the revascularization.
One extension to what Shastri sir asked. If we could perform it with a diagnostic catheter, perhaps you could pull the diagnostic catheter back and the LM pressure would give you a PA, which would help us.
We can do that, no problem. But what the against points are that if you were to dissect, then there is a problem. To dissect with the wire, one. Second is the pressures measured of the PA measured from a diagnostic catheter are different compared to that measured from a guide catheter. And that actually obviously gives rise to some differences. That's what they claim.
Do we really have any advantage of using a diagnostic catheter? Only thing is, at the time of angiography itself, you can do straight away with But now new techniques are coming up that can tell you at the time of, because the new things coming up will tell us.
I think we'll go to the next talk, sir. There was a study called Ripcord. Ripcord was a study in which they did FFR into all the 3 vessels. So the next speaker is Dr. Shrikant. While he comes, we'll just try to answer this so that we can have more discussion. In Ripcord, they looked at the angiographic measurement of stenosis and they by default did FFR into all vessels. In that study, they used in some patients diagnostics and in some patients guides. And both the concern that Dr. Rajesh has spoken of have been shown. They found a 44% change in the classification of which lesion was significant and which was not significant when they used FFR as opposed to angiography, including which part of the lesion needed to be revascularized. So nearly half the time they had to change their decision. That was the most important thing. But in the they have written that there was sometimes a difference when they used a diagnostic and a guide, because the type of diagnostic catheters available did not have the same tips as the guide catheter. This is all that is written in the study. So it's probably better for both the reasons that he has said. Pressure transmission from the tip of a larger guide catheter with a bigger lumen is always more reliable than what you get from a smaller diagnostic catheter. Even for the same size French, there is a difference in the inner lumen, and the pressure transmission is slightly more robust with the guide catheter.